As she just said, I'm Dr. Laura Farrington. I'm a DO and medical oncologist at Cancer Treatment Centers of America in Zion, Illinois, where I'm coming from today. Today, our topic is metastatic triple-negative breast cancer, what you should know. What I'm going to touch on today is I'm going to start with talking about what is triple-negative breast cancer and what makes it different. We're going to go through some of the basics of the classic treatment options, and I'm going to present some of the newest data over the last few years of the FDA-approved treatment options we have for metastatic triple-negative breast cancer. I'm also going to discuss what may be coming in the near future. So I'll start with talking about what triple-negative breast cancer is. When we're discussing triple-negative breast cancer, what we're talking about is a breast cancer that is estrogen and progesterone receptor negative, meaning that these receptors on the tumor itself are on less than 1% of the cells. We're also talking about a cancer that is HER2 negative, meaning that we do not see a HER2 gene amplification on the tumor itself. This is either found by IHC, which is a special kind of test on the tumor, which is 0 or 1+, or a FISH that is negative. Now, triple-negative breast cancer is a minority of breast cancers. It's only approximately 15% of all breast cancers, but they do tend to be more aggressive type tumors. They are generally high grade, which means that they are quickly growing. The most common type of triple-negative breast cancer is invasive ductal carcinoma, but there are several other types of triple-negative breast cancer. The most common subtype that we discuss is a basal subtype. If you see on this graph below, it kind of talks about the different subtypes of breast cancer. Luminal A, luminal B, HER2 positive being the other types. But most triple-negative breast cancers end up being basal type breast cancer, which again is a more aggressive type tumor. Now, triple-negative breast cancers generally occur in a special population of women. Most women with triple-negative breast cancer are younger. If you are diagnosed with breast cancer under the age of 40, it is much more likely that it is triple-negative than other types, although other types can still occur. We know that triple-negative breast cancer is more common among Black women, and this is found worldwide, not just in the United States. With triple-negative breast cancer, we do know that it is commonly associated with a BRCA mutation, and that 20% of patients with triple-negative breast cancer will have a BRCA mutation. Anytime I find patients with triple-negative breast cancer, I always have them meet with a genetic counselor to consider genetic testing. Because as we will talk about, if you do have a BRCA mutation, there are more treatment options that may be available to you. Triple-negative breast cancer is also more common amongst premenopausal females. Some of the other risk factors we see is young age at first pregnancy and obesity. We know that the more pregnancies you have, the less likely it is to get triple-negative breast cancer. And we do know that breastfeeding may be protective of triple-negative breast cancer. Now, when we talk about metastatic triple-negative breast cancer, what we're talking about is breast cancer that has grown and spread to other parts of the body. As we know, most of these cancers start in the breast. They can often first spread to a lymph node, and then the cells get into the bloodstream and go to other places in the body. Where it most commonly goes is to the lungs, the liver, the bones, and the brain. And I added on this slide the NCCN National Practice Guidelines about the workup for patients with metastatic breast cancer. With triple-negative breast cancer, I am much more likely to do additional scans to make sure we don't see disease in these areas. So for example, in a patient with back pain or a patient with headaches, it's important to get these MRIs of the brain and spine up front. PET scans also tend to be a little bit better in triple-negative breast cancers than other breast cancers because they are more aggressive and tend to show up better on PET scans. So I do get PET scans more often with triple-negative breast cancer patients. Now, when we talk about prognosis of triple-negative breast cancer, because it's more aggressive than other breast cancers, the prognosis tends to be worse. So on this chart, this is from the SEER database from 2018, looking at the breast cancer specific survival. And when we look at these breast cancers, as you can see, the hormone receptor positive, meaning estrogen or progesterone receptor positive, or the HER2 positive breast cancers do tend to have a better prognosis. And as you can see here, the triple negative breast cancer curve is lower, meaning that patients with triple negative breast cancer tend to die sooner of breast cancer. That being said, this data is from prior to the new therapies I'm going to discuss. So the hope is that in the future that this curve will increase dramatically. Now, these are some of the classic treatment options for metastatic triple negative breast cancer. Now, you see that I say classic, but this is actually a slide from 2016. So when we're talking about classic, we're talking about only 4 years ago. You know, just 4 years ago, really the only treatments that we had for metastatic triple negative breast cancers were chemotherapies. So drugs that kill quickly growing cells. Most patients use a single agent chemotherapy, and we use it for as long as it works and as long as you tolerate it. And if it stops working or you stop tolerating it, we switch to something else. Now, in patients with a lot of visceral disease, meaning things like large liver metastases, we sometimes use combination therapies as well. What we know is that if we use multiple drugs together, although it may shrink the cancer more quickly and help with symptoms more quickly, it has not been shown to improve overall survival. So for most patients, we use a single agent, meaning one at a time. Now, in terms of these classic chemotherapy options, they're kind of put into these different groups, these different subsets. The first subset are the taxanes. So those include paclitaxel, also known as Taxol, docetaxel, which is known as Taxotere, and nab-paclitaxel, which is known as Abraxane. Now, the taxanes are the ones with the single highest response rate for a drug. Now, which drug you pick is really based on the side effect profile in the particular patient. What we know about this drug class is that it is a class that does tend to cause neuropathy, which is numbness and tingling in the hands and feet. That is one of the most common long-term side effects we see and something we have to monitor closely. We know that these drugs tend to cause temporary hair loss, and in docetaxel in particular can sometimes cause chronic hair loss. And with all of the drugs we're going to talk about, one of the problems that we see is we see problems with decreased blood counts, which especially right now is important for us to be monitoring. You know, we certainly have medications that can help boost the white blood cell count and prevent infection. However, it is something that has to be monitored closely throughout therapy. Now, the second drug class on this slide is a class called anthracyclines. This is something, the drug most commonly used is called doxorubicin, known commonly to patients as the Red Devil. There are other drugs in the class, including epirubicin and pegylated liposomal doxorubicin, which is known as Doxil. Now, these are also drugs that tend to cause hair loss and decreased blood counts. The special side effects for this drug class include things like decreased pump function of the heart. So it's really important that we check the pump function of the heart prior to starting therapy, either with an echo or a MUGA scan. And we have to repeat those to make sure they aren't decreasing at least every 3 months. Now, all of these drugs have a maximum lifetime tolerated dose, which means these are not drugs that can be used forever. And so for some patients, even if they're having a great response, these drugs have to be stopped. The other issue with these drugs is they can cause secondary cancers down the line, things like leukemias. And so that's something that we monitor for, but can occur 7 to 10 years down the line. Now, the third drug class listed here are called antimetabolites, which include capecitabine and gemcitabine. Now, capecitabine is one of my favorite drugs to use because unlike all the other drugs we've talked about so far, it is an oral therapy, meaning that it's a pill that you take at home. and your liver actually converts it to a classic chemotherapy drug called 5-FU. Now, capecitabine is a little bit special in terms of its side effects. The common side effects we see are things like mouth sores or mouth soreness, as well as redness and swelling of the hands and feet, something commonly known as hand-foot syndrome. And so it's very important to keep the hands and feet moisturized, and it's important to make sure if you're starting a drug like this that you have a mouthwash to use in case you get that. Now, the second drug in the drug class is called gemcitabine. Now, gemcitabine is an IV therapy that we often use alone, but we can use in conjunction for patients with really aggressive triple negative breast cancer that have a lot of disease. We often use the combination of carboplatin and gemcitabine, which is something that we'll talk about the platinum agents in a few minutes. But with gemcitabine, the most common side effects that we see are things like decreased blood counts. Gemcitabine is also an IV therapy that's given more often. It's often given weekly or a few weeks on and 1 week off. Blood counts tend to be the major issue. It can sometimes cause things like rashes as well. Now, the fourth drug class listed are drugs called microtubule inhibitors, things like eribulin, vinorelbine, and exabebalone. Now, these are drugs that are all IV. The eribulin and vinorelbine are usually given weekly, generally for a few weeks on and 1 week off. The exabebalone is also known as Exempra, and it's given about once every 3 weeks. Now, with this drug class, we do tend to see hair loss, and we can see neuropathy, that numbness and tingling of the hands and feet. They also can decrease the blood counts. Now, the last agents listed are platinum agents, and we're going to talk a little bit about them again later in this talk. Platinum agents have found to actually work better for patients generally with triple negative breast cancer, and specifically for patients with BRCA mutations. So if you do have a BRCA mutation, these are agents that are commonly employed either on their own or in combination with some of these other drugs. The platinum drugs are usually well tolerated. Special things for them is we have to monitor things like the kidney function because it can affect the kidneys. It can also cause sometimes high frequency hearing loss, mainly with that cisplatin drug, but can also occur with the carboplatin drug. So if you're ever noticing changes in your hearing, tinnitus, which means ringing in the ears, or high frequency hearing loss, make sure you discuss it with your doctor. Now, like I said, classically, we used one drug at a time for as long as it works and as long as you tolerate it. And if we see growth of the tumor or we see intolerance, we often switch to something else. Now, those were the classic treatment options, and these are our current clinical practice guidelines on the NCCN. So as you can see, there are the drugs that I listed before, but also some new drugs. And so I'm going to talk to you a little bit about these newer drugs that have been FDA approved in the last few years that are specifically can help patients with triple negative breast cancer. So the first specific type of triple negative breast cancer I'm going to talk about are breast cancers that are PD-L1 positive. Now, PD-L1 is a marker that's found on the tumor itself. And with cancers that are PD-L1 positive, they're more likely to respond to things like immunotherapy. Atezolizumab was the first type of immunotherapy that was FDA approved for metastatic breast cancer. The way that this is given is it's given in combination with that nab-paclitaxel, also known as Abraxane. The clinical trial that got this drug FDA approved was for first-line metastatic triple-negative breast cancer, meaning that these are either patients that are found up front to have metastatic disease or patients that have recurrent metastatic disease. And they looked at about 900 patients with triple-negative breast cancer, and they randomized them to either get the Abraxane with atezolizumab, also known as Tecentriq, versus Abraxane alone. And what we saw is that for the PD-L1 positive group, they showed a significant improvement in progression-free survival, meaning there was a significantly prolonged period of time for patients prior to their cancer getting worse, prior to either new sites of disease or growth of a tumor of 30%. Now, this was published back in the New England Journal of Medicine back in 2018. And so what we see here is that this was approved by the FDA in March of 2019, looking at both the data for the progression-free survival and the overall survival. So again, progression-free survival means the amount of time that goes by prior to the cancer getting worse, prior to either having new sites of disease or to having a growth of a tumor more than 30%. And so when we look at this blue line, which is the combination of Tecentriq with Abraxane, you can see that patients are having their cancer kept under control significantly longer versus patients that got Abraxane alone. And then we looked at overall survival, which means how long patients lived. So getting these therapies up front, did patients live longer just from getting this one additional therapy? And as you can see on this second graph, that this blue line is significantly longer, that patients that got the combination lived on average several months longer than those that didn't. Now, in terms of side effects, this is a drug that's given with that nab-paclitaxel, also known as Abraxane. So with Abraxane, we still get those side effects, things like hair loss, things like neuropathy, which is numbness and tingling in the hands and feet, as well as decreased blood counts. Now, when we add on the atezolizumab to that, we do get more side effects, but these side effects are very different than chemotherapy type side effects. The way atezolizumab works is that it stimulates your immune system to treat the cancer. So the side effects that we get are from that immune stimulation. So if you look at the actual numbers in the trial, things that were more common in the atezolizumab group were things like nausea, cough, decreased blood counts, fevers, and hypothyroidism. Now, when I give these medications to my patients, I often talk to them about the risk of autoimmune issues. What that means is that because this drug is stimulating your immune system to treat the cancer, it can sometimes overstimulate the immune system and can affect a number of different organs. So one of the organs it can affect is the thyroid, and it can cause autoimmune hypothyroidism. Other common things that we can see are things like pneumonitis, which is inflammation in the lungs, hepatitis, which is inflammation in the liver, and colitis, which is inflammation in the colon. And so they should be monitoring your liver function tests regularly, as well as checking on things like diarrhea. Now, if a patient does come back with something like significant diarrhea or elevated liver function tests, they are often treated with things that calm down the immune system, like steroids. Oftentimes this works quickly, but there are certain immune issues that do not reverse with the atezolizumab. So for example, things like people can actually get autoimmune diabetes, which is really type 1 diabetes. And so that is something that even if we give steroids, it is often irreversible. Now, the nice thing about this combination is that we often give the combination together. So we give the Abraxane and atezolizumab together up front. And if people have good responses, we can often stop the Abraxane and continue the immunotherapy alone. Now, the Abraxane is given once weekly. You do it 3 weeks in a row, and you take a week break. And then with the atezolizumab, also known as Tecentriq, it's given once every 2 weeks. So if patients are getting too much toxicity from that Abraxane, we often continue the atezolizumab alone once every 2 weeks, and people can still get sustained responses even though they are not getting chemotherapy. Now, the second type of special population I want to talk about is those BRCA mutated patients. So like I said in the beginning, about 20% of patients with triple negative breast cancer have BRCA mutations, either in BRCA1 or 2. Now, the special treatments for them that may be a little bit different than patients that don't have a BRCA mutation are things like those platinum chemotherapies like I talked about before. We know specifically for BRCA mutated patients, those platinum chemotherapies tend to work better. There's also a special drug class called PARP inhibitors. PARP inhibitors are specifically for patients with BRCA mutations that are germline, meaning in all of their cells. And this graphic down here kind of talks about how PARP inhibitors work. That when you have a normal BRCA mutation, the PARP inhibitors don't do very much, or a normal BRCA, that PARP inhibitors don't do very much. But when that BRCA is either deleted or suppressed, that those PARP inhibitors can come in and actually, cause cell death, which is really what we want to do. Now, the two current FDA-approved drugs for this indication are olaparib and talazoparib. And so I'm going to talk about some of the data we have on that. Now, the nice thing about those drugs is that they are oral. So they're generally pills that you're taking at home. So not an IV therapy, which is really nice. So on the top left is the data for olaparib. And what they compare to is what they call, physician's choice chemotherapy. So the doctors in the studies, if you got randomized to the chemotherapy arm, could decide which chemotherapy they wanted to give. And they compared it to this olaparib, which is 300 milligrams that is given twice a day. And what we can see is, again, this is progression-free survival, so the amount of time before the cancer grew. And what we see with the olaparib is that there's a significantly prolonged period of time before the cancer progresses. On the bottom here is the talazoparib, which is, again, looking at that same thing, looking at physician choice chemotherapy versus this pill. And as you can see, this blue line shows that the specific targeted therapy, the PARP inhibitor, tends to work better than physician's choice chemotherapy. Now, the nice thing about these drugs is that besides the fact that it keeps it under control longer than chemotherapy, they actually demonstrate a significant quality of life advantage, meaning that people felt better on these targeted therapies rather than chemotherapies. Now, with these PARP inhibitors, although most patients tolerate them well, and all the side effects do tend to be dose dependent, which means if you have too many side effects, we can decrease the dose, there are still side effects we see. Most common side effects we see with these PARP inhibitors are things like fatigue, which is probably the most common side effect we see with just about every drug that we give. There is hair loss in about 25% of patients. It can cause nausea, vomiting, diarrhea, and constipation. Generally with these PARP inhibitors, what I hear the most of is just nausea. And some of my patients will have to take a nausea pill prior to taking the PARP inhibitor. They certainly can decrease the blood counts. So that is something that has to be monitored closely. And sometimes we do need to reduce the dose because of that. And it can affect the liver function test. So I really encourage my patients on PARP inhibitors to stay away from alcohol and to stay away from NSAIDs, things like ibuprofen, Aleve, Advil, and Tylenol. Now, this next drug that I'm going to talk about is the newest drug on the block, which was just FDA approved this year. It's sacituzumab govinotecan. It got accelerated approval by the FDA in April of this year. Now, this particular drug was FDA approved based on a clinical trial looking at patients that have had at least 2 prior lines of chemotherapy. So patients that have gotten a couple chemotherapies before, and then they tried this drug. Now, this is kind of a special drug, and it's a little bit different than a lot of other drugs that are out there. So what it is it's called a drug antibody conjugate. So there is the drug part of it, which is an active metabolite of irinotecan. So that's nice for us oncologists because most of us have quite a bit of experience with irinotecan because it's a common chemotherapy drug we use for gastrointestinal cancers as well as lung cancer. And it's coupled to this specific antibody, this TROP2 monoclonal antibody. So it's kind of like 2 drugs in one, where they have a monoclonal antibody, a specific targeted therapy that's attached to a chemotherapy. There are several other drugs for breast cancer that are FDA approved in this way. So, for example, drugs like Kadcyla that we use for triple negative breast cancer, which are also drug antibody conjugates. Now, this is a different kind of plot. So this drug was approved pretty quickly based on these good response rates. So if you look at this chart, this table to the left, what we see is the change in tumor size. So each line is actually a single patient that was on this clinical trial. And as you can see, there's some patients that did not respond to therapy, but a large majority of patients that either had stable disease or responses, including several complete responses. Now, what a complete response means is that we see no evidence of disease on scans. And it's not something we see very commonly after patients have had 2 lines of chemotherapy. So this data was really exciting to oncologists. We saw that there was a significant clinical benefit rate. What a clinical benefit rate is people that have had either a response or stable disease for a prolonged period of time. And so that there are patients that even if it didn't shrink the disease, if it kept it under control, it seems to provide clinical benefit. So as you see in this table, there were about 3% of patients that got complete responses. There were about 30% of patients that got partial responses, and about 37% of patients that got stable disease, which is much better than just about any other chemotherapy that we have, third line for metastatic triple negative breast cancer. Now, it didn't work for everybody. In 26% of patients, the disease progressed regardless. But that's very common what we see for treating triple negative metastatic breast cancer. And like I said, the clinical benefit rate is good, that a 45% clinical benefit rate, meaning that it either kept the cancer under control for a prolonged period of time or the cancer shrunk significantly. Now, the other nice thing on here is the median duration of response being 7.7 months. That means on average for the patients it worked for nearly 8 months, which although doesn't sound like a long time in layman's terms, in the oncology world and third line therapy for triple negative breast cancer, that is a good number. That is a lot better than a lot of other drugs that we have out there. So although this is a drug that is not necessarily curing triple negative metastatic breast cancer, it is giving patients a good quality of life and keeping their cancer under control. Now, we don't have the overall survival data yet, but that should be coming. Now, in terms of side effects of this drug, I've actually been pretty pleased with how my patients have been tolerating it. Most common side effects we hear about are nausea and diarrhea. It's pretty similar to that drug irinotecan that we know a lot about. And so although these things are common with the medications that we have available to prevent nausea and to prevent diarrhea, this is usually can be controlled quite well. It can decrease the blood counts and cause neutropenia. So we often use it with the drug to boost the white blood cell count. Now, it does cause hair loss in about 40% of people, and it can decrease appetite. But this is the newest drug on the block that has been FDA approved for metastatic triple negative breast cancer. Now, these next drugs I'm going to talk about are not specific to triple negative breast cancer, but they can sometimes affect patients with triple negative breast cancer. So more recently, the FDA has approved several drugs that are for any tumor type that have specific genomics. Now, what genomics are is it's looking for specific mutations in the tumor itself to see if there are targeted therapies or immunotherapies that may be available. Now, I'll tell you, for my patients with metastatic triple negative breast cancer, I get genomic testing on every patient that I can. Meaning that if there is tumor available, we look for these specific genetic changes because it may dramatically alter what we do. Some of the things we look for are these things like these NTRK fusions, as well as the tumor mutation burden. The tumor mutation burden is simply looking at how many mutations that we see in the tumor itself, because if you have a higher tumor mutation burden, it can also actually tell us that immunotherapy may be more beneficial. Now, some of the things that we also look for are these MSI high tumors, which are more common in other cancers, but can still occur in triple negative breast cancers. So I would encourage any patient that has metastatic triple negative breast cancer to make sure their doctor is getting genomic testing on the tumor. Now, usually the genomic testing we get is something called next generation sequencing, which is a way to check for a large number of mutations or amplifications with a very small amount of tumor. And so that's something I encourage all of my patients to do, and I generally order on the patients that I see the first time that I see them. Now, some of these mutations can change over time, but generally these fusions or tumor mutation burdens don't change dramatically over the course of treatment. Now, the first thing I'm going to talk about are these NTRK fusions. Now, these are pretty rare. However, can occur in specifically secretory breast cancers, meaning juvenile breast cancers, which can be triple negative. These NTRK fusions, again, are more common in the HER2 negative, and the most common breast cancer subtype that has an NTRK fusion are these triple negative breast cancers. So although these don't occur commonly, they're important to look for, because if you do have this mutation in the tumor, these therapy options may dramatically alter the course of the disease. So this is, again, one of the plots of larotrectinib, which is an NTRK inhibitor. And again, for each of these lines, this is a single patient. And this is how they are responding to therapy. So this is something that is really uncommon in oncology, and seeing these kinds of responses are really exciting and dramatic. So this was looking at a pooled analysis of the phase 1/2 clinical trials of larotrectinib. And again, each of these lines are a patient, and you can see the changes in the largest tumor size. And as you can see on the right side of the plot are those patients that have a complete response, meaning we see no evidence of disease after treatment. Now, the breast cancers on this plot are in the light blue. So you can see that there are these 3 light blues that have had fantastic responses to this particular drug. The response rate in this trial for breast cancer was 75%, meaning 75% of patients had more than a 30% decrease in the size of their tumors, which again is fantastic. Larotrectinib and entrectinib are oral targeted therapy pills, and they're generally very well tolerated. Most patients that are on these drugs tell me they feel like normal people, and not cancer patients that are on IV chemotherapy. Now, it still can have side effects, but they generally are pretty mild. We can certainly see fatigue, like we can see with most other drugs. These can cause sometimes fevers. Technically can cause nausea, vomiting, diarrhea, constipation, and decreased appetite. Probably the most common I see is that decreased appetite. It can affect the liver function test, so that's something that we monitor closely, and can cause cough and shortness of breath. But if you have an NTRK mutation, these drugs are fantastic, well tolerated, and work for most patients. Now, I will tell you there are certainly clinical trials ongoing for 2nd and 3rd generation drugs like this that are also getting some amazing results. So that is something that may be up and coming as well. I would expect over the next few years to have more drugs FDA approved for this drug class. Now, this other medication we're going to talk about is pembrolizumab. So it's another immunotherapy that's a PD-1 monoclonal antibody. And so again, it stimulates the immune system to treat the cancer. So works very differently than chemotherapy. Now, this pembrolizumab is currently FDA approved for any cancer with a high tumor mutation burden, which again tends to occur in triple negative breast cancer, and also in patients that are younger that get this disease. Now, what you can see is the mechanism of action down here is that it's got this anti-PD-1, which helps it to connect to the tumor cell and cause tumor death. Now, the nice thing about pembrolizumab is that the way that it's FDA approved for tumor mutation burden high is as a single agent, but it can often be paired with chemotherapies pretty readily and easily. And so I wouldn't be surprised if in the near future we have this drug approved with other chemotherapy drugs in the setting of triple negative breast cancer. So in the clinical trials, so first of all, about 5% of breast cancers have a high tumor mutation burden, which again is more commonly associated with triple negative disease and more aggressive disease. And what we know that specifically with pembrolizumab, they did clinical trials looking at these tumor mutation burden high, and we see these good response rates. So the complete and partial response rate was 29% with tumor mutation burden high. And that we do see a significant percentage of patients with stable disease. Now, this is an IV drug, and it can be given different ways. It can be given once every 3 weeks or once every 6 weeks. It doesn't have to go through a port or a PICC line, which is nice for patients if they don't have that. Now, these are not drugs that work for everyone, but for the patients that it does work for, they can sometimes work for really prolonged periods of time with really minimal toxicity. Now, again, in terms of side effects of pembrolizumab, it's similar to those side effects of atezolizumab. They're the same drug class. And so it can stimulate the immune system. So most common things we hear about are things like fatigue. We can hear about decreased appetite, sometimes rashes, sometimes fevers, and we do worry about immune overstimulation. So things like hepatitis, pneumonitis, colitis. But again, these things can often be really quickly reversed with steroids if needed. Now, I did want to also touch on some of the things in the other modalities that have been updates in the last few years. A lot of patients come in with metastatic triple negative breast cancer, and they have a tumor in their breast. And patients are often pushing to try to get surgery for the breast to see if it improves survival. So we've had several studies on this, and we've been trying to study this quite a bit for about the last decade. But there was a new phase 3 trial that was presented at ASCO this year. And this trial is a little bit different than the older trials in that they treated patients with systemic therapy first, so generally chemotherapy drugs. And if they didn't progress, so if either the cancer stayed stable or got better, they randomized them to either take them to surgery versus no surgery. Now, what they looked at is they looked at overall survival and progression-free survival. And what they saw in all breast cancers is that there was no significant difference in overall survival. That actually the overall survival rate looked very similar amongst the group. Now, the other part they looked at was quality of life. Do patients feel better if the tumor is out of their breast? And they didn't see any significant advantage to surgery in terms of quality of life. Now, this trial that I'm discussing here was looking at all breast cancers. And I'll tell you, in the triple negative breast cancer group, there was a prior study that was, I believe, done in India. And specifically, that study in India looked at surgery up front, followed by chemotherapy. And what they saw in the triple negative breast cancer group is that patients that had surgery up front actually had a decreased overall survival. So they actually lived a shorter period of time than those patients that did not have surgery up front. So although this doesn't pertain to every single patient, and there still may be patients where surgery could be considered, that based on the most recent studies, we have not seen an overall survival advantage to most patients with surgery. Now, radiation is something that is also often commonly used for metastatic cancer. Now, in the past, when we talked about metastatic cancer, we knew that radiation didn't seem to improve overall survival. We saved radiation to help with symptoms. So for example, if you had pain in a bone, we'd radiate the bone to help your pain go away. And that actually can work well and work quickly. Now, the newer types of radiation that people use commonly are called SBRT, so stereotactic body radiation, which means a high dose, short course of radiation. You know, classic radiation can be done for 4 to 7 weeks, and it's daily, and it can be trying on patients. And so trying to give a higher dose more quickly allows us to get that same radiation dose in, and often more quickly, and can work more quickly. So there was a recent study done looking at stereotactic body radiotherapy and oligometastatic and oligoprogressive breast cancer. Oligometastatic means generally that there's only one or a few sites of metastatic disease. So for example, patients with metastatic breast cancer with only one lung nodule. Now, oligoprogressive disease is something we commonly see with triple-negative metastatic breast cancer, that you have what we call a mixed response to systemic therapies. So that some areas of the cancer get significantly better, but perhaps there's one area that gets worse. So they looked specifically at SBRT for patients with metastatic breast cancer, and it was shown to be well tolerated with excellent local control. And they do recommend offering this for patients, again, with oligometastatic disease or oligoprogressive disease with breast cancer. Now, the other exciting part that people have been looking at is there's something called an abscopal effect. So in patients getting immunotherapy that do have radiation to an area of disease, they are seeing sometimes a improvement in the systemic disease, even though they're only treating one site. So that's something that has more clinical trials ongoing at this point. So in terms of what we're expecting for the near future, is we're expecting to get hopefully more options, more therapies, and more targets. So in terms of immunotherapy, you know, we have Tecentriq that's FDA approved. We have pembrolizumab that's FDA approved for specific subtypes. But looking at newer immunotherapies or things like CAR T cell therapy may be up and coming. We're also looking for more targeted therapies. Now that we're doing genomic testing on more patients earlier, we're learning more about what targets patients have to see if we can design drugs to treat those specific targets. And of course, we're looking at new chemotherapy options or combinations. So things like those drug antibody conjugates that can be like a double punch to the cancer. Also looking at seeing how we can give surgery with systemic therapies to try to make surgery more effective, as well as new and different radiotherapy options. So like I said, giving things like radiation therapy with things like immunotherapy to see if it boosts the immune stimulation. So, you know, in comparison to a lot of other cancers out there, we've had actually a lot of new and exciting things happen in triple negative breast cancer over the next few years. And I'm expecting a number of more to come in the next few years. So that is my main presentation. So I hope that you learned something about the treatment of triple negative metastatic breast cancer. And I believe at this point we are going to be opening it up so that I can take some questions.
Thank you for your presentation. It was very interesting. We had several questions come in while you were speaking, and people are invited still to add some more questions to the question and answer section. One of the first ones that came in was about just basically feeling comfortable about a healthcare system being up to date on the newest treatments of triple negative disease. Someone is wondering, how do they feel confident that their doctors and their healthcare system has the newest information? And as a follow-up to that, if they were to come and get a second opinion with you or somebody at CTCA or a team at CTCA, how would that second opinion be coordinated with
are open
their primary
for second
oncologist?
opinion. And a good way to know if your oncologist is following standard of care treatments or the most updated therapies is to get a second opinion. Most oncologists are very open to it. We're always happy to help with anyone else in the field. And these days, a lot of insurance companies have second opinions that you can go through. And so I would encourage anyone who is not certain if their doctor is making the right decisions for them to try to get a second opinion elsewhere. You know, a single office visit, especially these days that are available via telehealth, can be really helpful in helping you feel comfortable with your physician, and also helping to get another set of eyes and another set of brains on your case to make sure that you are doing everything appropriately and that you're getting the best care that's currently available.
Did they hear that?
I don't know. Can you turn on the volume on mine? Sorry, we're having technical difficulties here.
I'll try again.
Can you hear me?
I thought maybe closing this Zoom would help.
Nikki, I think you might be on mute.
Thank you. I'm sorry. Yes, we can hear you. I was wondering if you had anything else to add to your answer.
I'm sorry, could you repeat the question?
We are getting feedback. I think you might have two machines on at the same time. Or maybe your volume could come down on one of them.
Okay, let me see. Can you hear me now?
Yes, yes, that's
Okay.
perfect. That's perfect. You've been renamed Tom Martin, but we love that. Anything else you wanted to add? I wasn't sure if you were finished with your question. I felt like I may have interrupted you. Anything else you wanted to add about the team approach at CTCA and how that could be translated if somebody chose to stay with their local healthcare provider?
Well, I'll tell you, here at CTCA, we often provide second opinions, and we often do something we call co-managed care, where patients come to see us, we give them a second opinion, they do most of their chemotherapy or their other therapies with their home oncologist, and they come to see us when they need another opinion or when they're due for things like scans. So we work with home oncologists very regularly. We understand, especially in the midst of a pandemic, that it's not necessarily convenient for all patients to come out to Chicago, you know, every few weeks for treatment. And so we work with home oncologists regularly.
Okay. The next question that we have, sorry for the feedback, is people were wondering if there's specific things that women should ask their doctors when they're just a regular or a different kind of cancer. Are there specific questions that we should know about for triple negative patients? Areas to pursue further?
You know, I would definitely encourage patients to ask their doctors, especially about things like the next generation sequencing testing. You know, has my tumor been checked for PD-L1? Has my tumor been checked for tumor mutation burden? Are you sure that my tumor doesn't have any of those specific mutations like the NTRK fusion that may be targetable with treatment? So I would really, you know, encourage and say, hey, has this been done? And if it hasn't, is it something that we can do? Because it may open more treatment options. And then, of course, also asking about genetic testing. You know, if genetic testing hasn't been done, ask your doctor why it hasn't been done, especially in someone with metastatic triple negative breast cancer. You know, meeting with the genetic counselor is cheap and easy. And most insurances and most people are able to get genetic testing pretty quickly, easily, and cheaply these days. You know, a full genetic panel for someone without without any insurance at this point is less than $300 and can make a big difference on the rest of your life. So that's, I would encourage patients to ask their doctors these things.
Thank you. Another question about complementary therapies. We know that there's several of them out there. We're wondering if there are complementary therapies that you would recommend be added specifically for a triple negative breast cancer patient, or if there's focus on any specific ones that you would recommend and how that fits in to overall treatment.
In terms of, in terms of complementary therapies, there are numerous complementary therapies out there. You know, here at CTCA, we work very closely with naturopaths, as well as mind-body therapists and nutritionists. You know, nutrition can play a very important role in your cancer treatment, as well as things like supplements and as well as the mind-body connection. So there isn't one end-all be-all of, you know, everyone with triple negative breast cancer should be on this particular supplement. You know, right now we have quite a bit of data showing things like having optimal vitamin D levels may decrease the risk of tumor recurrence. It can help with bone strength and energy level, and it may also provide some support for your immune system if you get COVID. People are less likely to get hospitalized or in the ICU. But not everyone needs the same amount of vitamin D. You know, supplements need to be different. And so, you know, following with someone like a nutritionist or a naturopath in conjunction with your oncologist can make a big difference. And one of the things I like about working at CTCA is we have fantastic naturopaths and dietitians that we work with every single day, so that if a toxicity from treatment comes up, like neuropathy, the naturopath can talk about ways that they can treat that isn't going to harm you and that may benefit the cancer. You know, other common issues that women have are things like vaginal dryness, and there's a lot that a naturopath can do to help with that in terms of supplements or other physical things that people can do that aren't necessarily drugs. And so, unfortunately, these things, it's not a one size fits all answer, that every person is different, every cancer is different, and the side effects to treatment are all different. So when we're talking about complementary therapies, we want to make sure that they're using something that's right for you and that does not interfere with your cancer treatment. So it's important to follow with someone regularly if you're considering things like supplements, and talking to someone who knows what they're talking about. You know, naturopaths that work regularly with cancer patients.
As opposed to trying something on your own and thinking, oh, this is making me feel better. You should have
That's correct.
Okay.
Especially, you know, chemotherapy drugs, like one of the ones that I presented is a chemotherapy drug called Xeloda or capecitabine. And that is a drug that specifically, some medications or supplements that have B12 or folate can actually worsen the side effects and decrease the efficacy. So you want to make sure you're telling your doctor every supplement that you're on, and you want to make sure you're not taking things that can interfere with your chemotherapy. And unfortunately, a lot of oncologists are just not well versed on what complementary and alternative therapies can be taken with the chemotherapies that they're on. So a lot of oncologists just say, don't take anything. I really am fortunate to have some fantastic naturopaths that I work with that know very well each individual chemotherapy drug, what complementary therapies can be used with it, and what complementary therapies should not be used.
As far as more physical complementary therapies like exercise programs or yoga or Reiki or acupuncture or even PT and or just general exercise, do you have feelings on those things being added into this to your treatment? Should those be monitored as well?
We know that patients that that exercise regularly, that stay active, tend to do much better than those that don't. Now, that being said, you know, one of the common places that metastatic breast cancer likes to go is places like the bones. So you want to do the right types of exercise, and the last thing you want to do is exercise and break a bone. And so again, knowing where the cancer is, knowing what is okay for you is important. So knowing where your bone tumors are, so knowing that if you have a bone tumor in your right femur and your right leg hurts when you exercise, you know you shouldn't do that type of exercise. But we know that alternative or complementary therapies, you know, generally we consider acupuncture to be safe and effective for certain things like neuropathy. Regular exercise can make a difference for everyone. And even things like massage and chiropractics can have a place. It's simply, again, using a practitioner that knows enough about cancer. You don't want a chiropractor to, you know, physically crack your back and break a bone. But we certainly have a chiropractor we work with regularly here, and he asks me if it's okay to do these things or those things and what areas of the body to work on or to avoid. And so it's really important to have all of your providers have a good relationship with each other.
That makes sense. That makes sense. Let me see what other questions came in here. Somebody was asking more about they would like to have more information. You refer to it as SB radiation therapy. Can you explain a little bit more what that research and treatment is about and what stages that's in? What the promise is there?
So I believe what you're talking about is SBRT, which is stereotactic body radiotherapy. So SBRT is a specific type of external beam radiation. You know, classic external beam radiation is what a lot of women go through, for example, when they're going through regular breast radiation with early stage disease, that it's daily for several weeks. And that can be really time consuming. It can be expensive. SBRT is giving a higher dose of radiation to a smaller area to treat a specific issue. So for example, a single lung nodule, and giving a high dose to that single lung nodule, sometimes even in just one day, that can be very effective. It can work very quickly. And that the long-term consequences are less because you're treating a smaller area. And so there is quite a bit of data on that. It's, you know, there's been a lot of studies over the last 10 years or so. And it's something that we do regularly for what we call oligometastatic disease. So either a single area of disease that's progressing, or if there's only a single area of disease in your body, that if we do radiation to that area, it can sometimes eradicate that area, meaning kill the cancer cells there completely to prevent recurrence, at least in the area that we treat. You know, systemic therapy, the chemotherapy, the targeted therapies, the immunotherapies treat the whole body, whereas these radiation treat only where you point it. So there is a lot of data on SBRT, and now we are being able to get insurance companies approve these things more as we get data, because usually the hiccup is just getting insurance to approve it.
Right, right. That's interesting. And maybe just, this is a basic kind of question, but can you tell us, what is it about triple negative breast cancer that makes it such a challenge to treat? Is it just the unknown, or is it more complicated than that?
Well, triple negative breast cancer, first of all, it occurs in younger, healthier people generally. You know, it's younger women. It's women with less other comorbidities. Which makes us want to be more aggressive with therapy. The hard part is, you know, by definition, triple negative breast cancer doesn't have specific targets. You know, we know women with estrogen receptor positive breast cancer, we can often keep them on hormone pills with targeted therapy pills, usually for years, which is not the case with triple negative breast cancer. So it's for oncologists, it's now looking for what are the targets. We know that patients with triple negative breast cancer can have targets. Sometimes we can target the, you know, immune system in PD-L1 positive patients. Sometimes we can target the androgen receptors. Sometimes we can target those specific mutations, but it's just difficult because most women with triple negative breast cancer, their tumors don't have specific targets we have drugs for yet. But I would definitely say that that is yet, that I think that that is in the horizon, that we will actually be redefining breast cancer in the future to a number of different diseases and not just ER positive, HER2 positive, or triple negative.
So triple negative could become its own multi-class of cancer,
Exactly.
called this targeted and that targeted cancers.
Exactly.
Okay. I think that's a good place to, I don't see any more questions that have come in, but that's a kind of maybe as a last question. You may have already, you touched on this, but do you see triple negative therapies catching up to other breast cancer therapies?
I sure hope so. That's what we're all looking for.
That's right.
Well, thank you so much.
Yeah, thank you too. And I'm sorry about the technical difficulties. You are our pilot program, and apparently we've missed on a few counts, but the presentation was lovely. I hope everybody got a glimpse of your face while you were presenting. We'll make sure to put something out to everybody so they can see what you actually look like live and in person. Your bio is attached to this session on the agenda, so people can go in and read more about you and find out more about you. Any closing thoughts you have for our audience?
I would just say with triple negative breast cancer, it's not the end of the world. This is just the beginning of our new data, and that there are a lot of treatment options that are out there. So it's important to work with your oncologist to figure out what treatments are right for you. And whether that be with your oncologist or getting a second opinion elsewhere, to make sure that you are getting the best treatment possible, that there is hope, that there are people that do well very long term, and that we are getting more and more of those women. So I am happy to see this evolution of treatment of triple negative breast cancer, even just over the last 5 years.
You make us all very hopeful. Thank you. Thank you, Dr. Farrington. This is, for everybody out there in the audience, this was Dr. Linda Farrington. She works out of the Chicago Hospital location of Cancer Treatment Centers of America. Some of us know it as CTCA. The presentation was called Metastatic Triple Negative Breast Cancer, What You Should Know. If you know somebody who missed this presentation and would like to see it, as soon as we can, we'll get the recording up under the session. And thank you to the audience for your time, your patience in this case, and your questions. We hope you found this presentation enlightening. And hopefully we'll see you next Thursday for a presentation on financial planning considerations after a metastatic breast cancer diagnosis. And in the meantime, feel free to keep engaging with sponsors, organizations, presenters, and participants on the Whova app. I hope you navigate yourself through that. There's lots of potential there for communicating with each other, communicating with our presenters and the organizers and all the great sponsors. Thank you to everybody for being here today. Thank you especially, well, Tom, thank you back in the background. And thank you, Dr. Farrington. We really appreciate your time.